Pleasure and honor to be interacting with all of you today. I want to thank you for the kind introduction. What I'll do is I'll dive into the story a little bit, and for those of you that don't know, look, the genesis of this company is really in the realization of the large opportunity and inefficiency in U.S. healthcare. I don't know how many of you realize, but the U.S. healthcare industry is a $4.8 trillion industry. And we talk about India's GDP being $3.5 trillion, growing at 6.5–7%, and what a great opportunity it presents. I totally agree, being an Indian. But think about US healthcare, $4.8 trillion, growing at 7–8% with absolutely no cyclicality. Why no cyclicality? Because more and more people in the US need healthcare, population is aging, lifestyles are getting sedentary, chronic lifestyle disease, diabetes, COPD, congestive heart failure is on the rise. That means more and more people need care. As more and more people need care, healthcare will keep growing with absolute secular structural manner. So that's the type of opportunity set that US healthcare presents. And when we were starting this business back in 2006, the US healthcare ecosystem was going through what I call the perfect storm of cost quality access. What do I mean by that perfect storm of cost quality access? At 20% of GDP, US spends more as a percentage of their GDP on healthcare than any other advanced economy in the world. Their GDP is growing at an average of 2–3%, barring these COVID years, and yet healthcare is growing at 7–8%. So they're spending more than any other advanced economy, they're on a huge budget deficit, and their growth of healthcare is 7–8%. That means you have a fundamental cost problem. Second, you have an access to care problem because the number of patients that need care is growing much faster than the number of doctors, nurses, caregivers to provide the care. Why is that happening? Because chronic lifestyle disease is on the rise, and that creates the need for more and more care. So today patient access is a big problem. What do I mean by patient access? New patient wait times for primary care doctors, for example, are 45 to 60 days. For specialists, that number goes to 6 to 9 months. So you have a cost of care problem, you have an access to care problem, and then you are starting to create a quality of care problem. Why? Because US healthcare is highly regulated. And the regulators, in order to bend the cost curve and improve quality of care, keep introducing newer and newer regulation. And the unintended outcomes of that regulation is what I call a whole bunch of administrative tasks that get created, that these doctors and nurses get further saddled by. So in a world where doctors and nurses need to see more and more patients to improve access to care, today they are spending more than 50% of their time on non-patient care, non-discretionary tasks. That is creating this whole phenomena called administrative burnout, and that administrative burnout is leading to quality errors. And Johns Hopkins University in the US publishes an annual statistic of number of deaths due to medical errors. That number is north of 150,000 today. So that's why I call it the perfect storm of cost, access, quality. And when such perfect storms are brewing in such a large industry, there are some fundamental transformations that happen. One such transformation that we saw coming is what I call the transformation from reactive, hospital-centric care delivery to proactive, physician-led and patient-centric care delivery. What do I mean by that? So think about it. If your predominant cost of care is driven by chronic lifestyle diseases like diabetes, like congestive heart failure, if you try to manage that cost in a hospital-centric model, you will never succeed. Why? Because the hospital is the most expensive point of care within the continuum of care. And so you have to move to a situation where you manage these patients from the physician's clinic. Because in the physician's clinic, the physician can proactively engage with the patients and help counsel them to change their lifestyles. Changing of lifestyles might lead to preemption of disease states that lead to situations like hospitalization. So we chose to focus on that physician clinic, outpatient ambulatory setting as it's called in the US, when we decided to build our business in sync with this transformation from reactive hospital-centric medicine to proactive physician-led and patient-centric medicine. Now that physician market in the US is really about a $1.5 trillion market. So about 30% of the $4.8 trillion is reimbursed in the physician clinic. And when we were getting started, that was a highly cottage industry, entrepreneurial industry, where 65% of the 900,000 physicians in America existed in groups of 5 or less. So highly fragmented cottage entrepreneurial industry. But what we saw coming was a massive wave of structural secular consolidation in the physician market. By that I mean there would be 3 manifests of consolidation. One, large hospitals and health systems that have big balance sheets would start to buy the physician clinics and employ the doctors. Why would they do that? Because in the end, if you have to go to a hospital, which hospital do you go to? You go to the hospital that your doctor refers you to. So in order to get the downstream referrals, the hospital system started buying the physician practices and employing the doctors. Second, when you have a $1.5 trillion industry growing at 7.5%, 8%, in an economy that's growing at 2.5%, 3%, a lot of private equity money finds its way into that industry. And private equity came into the physician market and started consolidating them. And that created very large physician corporations, multi-billion-dollar physician corporations, funded by private equity. Some of them went public over a period of time. So as this structural consolidation would manifest itself in that $1.5 trillion physician market, we realized that what would happen as a consequence of that, when any industry goes from what I call a entrepreneurial cottage industry to an enterprise scale industrial grade industry, one of the transformations that naturally happens is what I call this rediscovery of the core versus chore equation within the task continuum of the industry. The smart enterprises, they figure out what are some of the core tasks in which they should focus all their energies. That's where they create the most differentiated value. And a lot of the chores that are important but might not be where they create differentiated value, they decide to delegate those chores, outsource the chores to some entity or platform that can do those chores better, cheaper, faster at scale. We set out to basically build such a care enablement platform that would take these chore tasks from these large physician enterprises to do them better, cheaper, faster at scale. So that was the first step of that journey back in 2006, was to discover what is the core, what are the core tasks for a physician practice and what are the chores. As you can imagine, what is the core task in a physician's clinic where the physician can create the most differentiated value? It's the patient experience. If they create a differentiated patient experience, if they engage deeply with the patient, clearly they would create a differentiated experience, right? So patient experience, the way they contract with the insurance companies, often they can apply intelligence and get better rates. So that is one place where they can create differentiated value. How they minimize the clinical variance of the care being delivered across various physicians in the enterprise, that can create a whole bunch of differentiated value. So those are some of the core tasks. To identify the chores, we actually did a simple principle. We use a principle of, task pyramid. What is a task pyramid? In any industry, there's a task pyramid. On top of that task pyramid sits the highest cost, most qualified worker doing the most discretionary task. In healthcare, that highest cost, most qualified worker is the physician. But they are spending more than 50% of their time doing non-discretionary tasks. That means that task pyramid had to be reinvented. And to identify the chores, we looked at the entire continuum of the physician's practice and we said, if there is a task that need not be done by the physician, let it not be, it might be a chore. Second, if there's a task that need not be done in the clinic, let it not be, it might be a chore. So that created a whole bunch of potential chores. Then we applied the second set of lenses to that, which was which of these chores can we do better, cheaper, faster at scale, leveraging the 2 things that we would use to do these tasks. What was the 2 things we would use? We would use those 2 pillars of efficiency on which capitalism stands. What are those 2 pillars? First, technology. I am a recovering computer science engineer by training, so we said we'll write proprietary technology to eliminate the tasks altogether. But because we're also pragmatic in our view of technology, we realize that technology often doesn't totally eliminate the task. It still needs a human in the loop. And especially in healthcare, where safety of the task is really important, human supervision of the task that the machine is doing is really, really important to do the task safely, because machines have biases, machines have hallucinations. You've all heard of hallucination issues in Gen AI. And so we definitely need a human in the loop. So hence, we would combine the proprietary technology that we would build with global humans, because there's anyways a huge shortage of labor in the US, so there was no way to scale the human part in the US. So we said we'll scale the human part in India and we'll build proprietary technology to eliminate these tasks. And when we applied all those lenses, what came out is what I call this continuum of about 16 tasks that became the 16 chores that we would delegate for these physician practices. And when we looked at them and we understood them, these tasks are nothing but things that happen along the patient's journey with the physician enterprise. And we basically, for ease of understanding, broke these 16 tasks down into 4 phases of the patient's journey with the physician enterprise. One, what are the tasks that can be taken away prior to the patient's visit with the physician enterprise? Second, what are the tasks that can be taken away during and around the visit? Third, what are the tasks that can be taken away immediately after the visit? And fourth, what are the tasks that can be taken away in between successive visits that a patient might have with the physician enterprise? Now, these 16 tasks now became the 16 features of what is now called our care enablement platform. And we realized that these physician enterprises were spending nearly 15% of their revenue on these chores. So on a $1.5 trillion revenue, 15% is $225 billion. Now, just to put in perspective, the entire Indian offshore software services outsourcing industry, IT services industry that you guys know, is about 250 billion. So we had found a total addressable market, a TAM, that is nearly the size of the entire Indian offshore software services industry, growing at 7%. And of this 225 billion, so far only about 35 billion has been outsourced. So the market is still highly underpenetrated, largely insourced, and the outsourced TAM of 30 billion, 35 billion of that 225 billion is actually growing at 12% because now they realize they have no choice but to outsource more aggressively because they're not being able to sustain the paradigm of being able to do these tasks in-house. There were a few other concepts with which we decided to build the business. One, we decided on an outcome or a SaaS-based pricing model. In that pricing model, the customer had no visibility to how many people were being deployed to do the task versus how much tech was being deployed. Now, this is an important distinction for our business as you understand it because when you look at other sort of BPO or KPO type businesses you might be familiar with, they get paid based on the number of people they deploy. So when technology reduces the number of people they deploy, they erode their own revenue. So things like Gen AI are a risk in that business. In our business, because our pricing model is either outcome based, which is percentage of customers' revenue, or SaaS based, which is subscription fee per physician user per month, when we reduce the number of people doing the task through technology, modern technologies like Gen AI, our margins actually go up, our revenue doesn't erode. And so that becomes a fundamental differentiator where these modern technologies are a huge tailwind in our business versus being a headwind in a classic outsourcing business, which is why we say what we have built is a platform as a service versus some sort of a services outsourcing business, right? So that was one important distinction. The second was we decided that in a market that's consolidating, which the physician market was, we wanted our clients to be the consolidators, which are the large guys are buying everybody else. We get them as the clients, then their natural inorganic growth becomes our natural organic growth, and we don't need to keep acquiring newer and newer customers to grow rapidly. And then last but not the least, we basically built out this model where each of these features essentially had proprietary technology embedded in it that we would build in close partnership with our customers because these technologies are based on very nuanced workflows of healthcare providers. You cannot sit and build these workflows in a lab. You have to work in co-development with customers to actually figure out these workflows and then figure out how to disrupt them or delegate them. So that was really the go-to-market thought process. Value proposition was simple, very compelling financially because they were spending 15% of their revenue. We would do it at 10% of their revenue, give or take. And so that's 500 bips in cost savings. But more importantly, by taking these tasks away, you would save doctors, nurses as much as 2.5 hours a day, which means even if they took 1 hour of those 2.5 hours to say lifestyle improvement, even if they brought back 1 hour to practice, they would see 2 to 3 extra patients a day, which means if they were seeing 20 patients a day earlier, which traditionally a primary care physician does, 2 to 3 extra patients a day on the same fixed cost is a huge uptick in revenue, right? So basically we saw through the full manifest of this platform, they could improve their revenue by 500 bips as a percentage of revenue. They could reduce their cost by 500 bips. That creates a 1,000 bip value creation opportunity. which means if they were barely 10% EBITDA businesses, they could nearly double their EBITDA at the full deployment of the platform, which becomes financially a very compelling value proposition. And then emotionally, it strikes to their mission, because now doctors are spending time doing tasks that they became doctors for, which is taking care of patients. They didn't become doctors to do tasks driven by regulatory burdens. Second, the physician-patient engagement improves dramatically because now the doctor is much more focused on the patient. So one, they are seeing more patients, so access to care improves. Second, they're more engaged with patients, so quality of care improves. And third, because they have time, they actually are better prepared for the patient visits. That gives them a chance to actually bend the cost curve. So it actually attacks that mission of cost, quality, access. So with all that, we started the business essentially back in 06. And the first sort of 15, 16 years of our journey was purely organic growth. We grew the business to about 150 million odd in revenue. We had strong unit economics, nearly 38-39% EBITDA margins. And the business was growing healthily in the mid-20s organic growth. At this point, what we started to see was the market was inflecting. Remember I said only 30 billion of the 225 billion had been outsourced so far. We saw that outsourced TAM starting to grow at 12%, even though the healthcare industry itself was growing at 7 to 8%. And as we looked at that, it became evident to us that this is that inflection point from which this 30 to 35 billion over the next, say, 15, 20 years will grow to 150 to 200 billion, just like it happened in the offshore software services industry, where it grew from like 3 to 4 billion in the mid-90s to 100 billion by 2010, and then today it's been 250 billion, right? So once we realized that that was the inflection that was happening, we said, what is our competitive positioning so that we can capture an unfair share of this market? And to understand that, it became evident to us that when you have such a large TAM of $225 billion, the individual TAMs of many of these tasks itself are 10, 20, 30 billion dollars. For example, we have a clinical documentation feature within the peri-visit phase of this patient journey called Scribble. That TAM of that feature itself is 30 billion. So when you have such large individual TAMs, a lot of companies get built up that I call point solution companies that are focused on just solving one task or two tasks or three tasks. Yet, as the providers were consolidating and becoming more mature, their buying behavior was moving much more towards the platform, which is they realized they can't be buying 10, 12, 14 point solutions from 14 different vendors, integrating those point solutions, managing so many vendors. So their buying behavior would shift as they matured towards the platform thesis, where the value of the whole is much greater than the sum of the individual parts. And we started positioning ourselves as the only company in the world that had built the full breadth of the comprehensive care enablement platform that would be required to delegate all of these chores. So essentially our competitive positioning and our strategy became that we had to continue to be number 1 or 2 or 3 in each of the individual features, even as we became the only company that was building the whole platform, which is where the buying behavior was migrating to. And that's really what we did. And as we were continuing to grow the business with the healthy unit economics that I spoke about, what happened was a very interesting company came across. At this point we had grown the business where we had nearly $100 million of net cash on the balance sheet, no debt. And we ran into this interesting point solution company called Acuity Holdings. So Acuity was a very interesting company. Compared to our 150 million in revenue, they also had 150 million in revenue. But compared to, we had only about 45 large clients. Remember, we were focused on the consolidators. So we had 45 large clients. And those 45 large clients had about 35,000 doctors employed across them. Acuity, for their 150 million revenue, because they had only 2 features, had about 800 clients. Of those 800, 500 were the large consolidator types that would be of interest to us. So those 500 that would be of interest to us employed about 120,000 doctors. We had 45 odd that employed 35,000 doctors. Together, we would have a customer base that had 155,000 of America's 900,000 physicians. That's nearly 18% of all of America's physicians. So when we modeled the cross-sell possibility of our 16-feature platform across all of these 155,000 physicians, it creates a revenue opportunity of nearly $29 billion. Together, combined, we would be about a $315 million company. So we were convinced this creates a massive growth runway for the next 15, 20 years as this large TAM unlocks and the outsourced TAM goes from 30 billion to whatever 150 billion that it will in whatever time horizon you take, next 10, 15, 20 years. And so that became a very powerful driver for us, for our interest in Acuity. The other piece that we had to navigate is that Acuity had very low operating margins. Unlike our 38, 39% EBITDA, they had only about 12% EBITDA, simply because they had no tech leverage. They were doing all of these two tasks using humans, and most of these humans were based in the US, $20 million, of which we took about $120 million in debt because we had $100 million of net cash, which was a conservative amount of debt relative to the combined earnings profile of the business. And we've been on this journey of effective integration, activating the cross-sell motion, and optimizing margins. Happy to note, this is what the financial performance seems like over the last 3 fiscal years, full fiscal years, 22-24. If you look at revenue growth, very healthy revenue growth of 54% CAGR. Even if you strip out FY24 Acuity contribution of 5 months, the legacy iCase business is still growing at 27% CAGR. EBITDA growth has always been faster than revenue growth. So hence, for our 27% standalone EBITDA growth, we had a 37% 27% standalone revenue growth, we had a 37% standalone EBITDA growth. And obviously the EBITDA to PAT conversion was very high because we had no debt, we had really no capitalization because we used to expense all our R&D expenses, all our product development expenses. So EBITDA to free cash flow conversions were always high, and hence EBITDA to PAT conversions were very high as well. And we've been on this journey, and happy to note that as we updated the RHP with our September 30th financials, we've actually been able to significantly improve the Acuity operating margins. Hence, our blended margins that had dropped to 24% on a pro forma basis when we acquired Acuity have now increased to 28% as of September 30th, which gives us the confidence that we will continue to drive that journey of margin optimization as we transform Acuity's margins. So really, I think in summary, you have probably one of the best leadership teams in the industry driving a mission of enabling better, safer care in the US, and in the process creating outsized growth for this space. And really, if you get a chance, we also have a really strong and marquee board. It consists of 4 highly strong industry stalwarts. Dr. Mary Klotman is the Dean of Duke University School of Medicine. Terry Stone is the CEO of Oliver Wyman's Healthcare Consulting Division. We've got a couple of other industry luminaries in Carl King and Tony Jones. And then, of course, appropriate representation on the board to represent the Jhunjhunwala families holding in the company, as they are one of my co-promoters. And that's reflected in Mr. Utpal Sheth and Mr. Goyla, and then a non-executive chairman in Mr. Burgess Desai to drive the higher standards of corporate governance. Leadership team consists of industry stalwarts that have built their entire careers in healthcare, and we're on our journey to hopefully create what will be one of the leaders in this space as this TAM inflects from the 35 million outsourced to the hundreds of millions that it's likely to be.